Over the last 10 years, the Department of Radiology at the University of Florida College of Medicine has conducted a simulation-based evaluation of radiology resident competence in critical care imaging. 316 residents interpreted this case of femoral neck fracture as one of 65 cases during an 8-hour simulated on-call shift, with a median score of 0 out of 10 and an overall average score of 2.48 out of 10. Overall, the average number of points lost out of 10 to observational discipline was 6.71. At the same time, 0.81 points were lost due to interpretive errors on the part of the residents. We define an effective report to be one which achieves scores between 7 and 10. In terms of letter grades, this would be an A or a B. In this most missed case, 25% of residents produced effective reports. We define a report having a critical error to be one with scores between 0 and 2. In terms of letter grades, this would be an F or a D. In this most missed case, 66% of residents produced reports with critical errors.
This is a pelvic CT in a 79-year-old with hip pain. There's asymmetric cortical irregularity at the left lateral femoral head neck junction, consistent with a valgus impacted left femoral neck fracture. We can see the fracture line extending all the way through the subcapital femoral neck. There are a number of other chronic findings on this case as well. This case should be given an acuity ranking of emergent and should be immediately communicated to the referring provider. So femoral neck fractures can be very easy to miss on CT, particularly if the fracture is minimally impacted and if the bones are only reviewed on the axial images. This finding can also be mistaken for degenerative changes, so comparison with the contralateral side is very helpful. So I personally check the femoral neck on the coronal reformatted images on every abdomen pelvis CT that I look at. I've now seen a number of cases where the clinical concern was for diverticulitis or bowel obstruction or some other intra-abdominal entity, and the cause of the patient's pain was actually a femoral neck fracture. If this fracture goes unidentified, the patient may continue to bear weight, which can increase the degree of impaction and thus increase the rate of femoral head osteonecrosis, which is one of the complications we are trying to avoid. Thus, radiologists can really make an important contribution to patient care if they make this finding. The location of femoral neck fractures can be described as subcapital, transcervical, or basicervical. The subcapital and transcervical fractures are at higher risk for osteonecrosis of the femoral head. The valgus impacted subcapital femoral neck fractures are at particularly high risk of femoral head osteonecrosis, as the lateral epiphyseal artery inserts right at this location. The lateral epiphyseal artery is what provides much of the arterial supply to the femoral head.